What is the Dix-Hallpike maneuver? This simple orthopedic test is able to differentiate is someone having dizziness with movement. And that's a big differentiator. There are some things that are constant, unrelenting dizziness, and those fall outside of what we do as evidence-based chiropractors. However, the majority of dizziness falls right into what we can do in practice. It's the patient that's getting up from your table. It's the patient that rolls over in bed and gets dizzy. It's the patient that turns their head when they're backing up their car and gets dizzy. That is what we can treat in our office. Most commonly, it's BPPV, benign paroxysmal positional vertigo. The way that we can attest this is we can look at the Dix-Hallpike maneuver. It is very good at diagnosing the most common type of BPPV, which is posterior canal BPPV. When you do Dix-Hallpike maneuver, the main thing is you're testing the side that you're rotating towards. So when you have them in the long sitting position and they rotate their head to the right, what you're testing is the right-sided posterior canal and the left-sided anterior canal. Now, as it turns out, the only way you can really get anterior canal BPPV is by standing on your head. So short of being in a circus or being in a random yoga position, we don't see a lot of those patients coming into our door. What we do see is posterior canal BPPV. In fact, up to 90% of people have posterior canal BPPV. After you do the Dix-Hallpike maneuver and you have the patient laying down with their head rotated, what should you be looking for? And as it turns out, there's two things. One is reproduction of vertigo, a spinning sensation. Usually that's going to subside within 15 to 30 seconds. But the second piece I really didn't know is that you also need to be looking at nystagmus and correlating what is the difference between vertigo and nystagmus or just vertigo. So when you have Dix-Hallpike maneuver that's positive and you get just vertigo, just the feeling of dizziness, this is called subjective BPPV. You have to have vertigo and nystagmus, which in the posterior canal is an upbeating nystagmus, in order to have objective BPPV. And this is important because people with objective BPPV respond very well to Epley maneuver and sending them home with Brandt-Daroff exercises. You can find all those in Chiro Up. These patients are perfect. They fit right into the diagnosis. You did the right orthopedic exam, you did the right treatment, and you're giving them the right at-home rehabilitation. There are some people that don't fit in that model. Those are the people you need to start looking elsewhere. In this case, you can send them to an ENT. There are specialized equipment to help look for, is there actual nystagmus that you can't detect? However, there's a big population of these people with subjective BPPV that it's not the inner ear that's causing their symptoms. Yes, movement is. What else can we look for? The most common is cervicogenic vertigo. Do your head fixed body turn test. Check out Chiro Up and look at the cervicogenic vertigo protocol. Those are the patients that are wonderful for us. They respond well to manipulation and to doing similar exercise and at-home rehabilitation. So if you can get the right diagnosis for the right patient and give them the right rehab, your clinical success goes up, your patient satisfaction goes up, and your Google reviews also go up. I hope this helps. If you have any other questions on BPPV or the differentiators between that and cervicogenic vertigo, check out Chiro Up. We're here to make your life easier.